Welcome to Nursing 130, Chapter 11, High Risk Perinatal Care, and we're going to be talking about pre-existing conditions. For some women, pregnancy represents significant risk because it's superimposed on a chronic illness. Unique maternal and fetal needs caused by these conditions must be met in addition to the usual pregnancy-related feelings, needs, and concerns. Some of the pre-existing conditions that we're going to be talking about are metabolic disorders, including diabetes mellitus and thyroid disorders. We'll also talk about cardiovascular disorders and substance abuse. In preparation for this lecture, I'm going to assume that you have the basic understanding of diabetes, so I will be focusing on how this condition affects pregnancy. Diabetes mellitus is the most common endocrine disorder associated with pregnancy. Pregnancy complicated by diabetes is considered high risk. Diabetes can be successfully managed with a multidisciplinary approach, and the key to optimal outcome is strict maternal glucose control. The pathogenesis. Diabetes is an endocrine disorder with major effects on carbohydrate metabolism, as you probably know. It results from insufficient insulin production in the beta cells of the islets of Langerhans in the pancreas, or from inadequate use of insulin. Insulin facilitates the movement of glucose from the blood into the tissue cells for fat storage and energy use. So to review, it's a group of metabolic diseases characterized by hyperglycemia resulting from defects in insulin secretion, insulin action, or both. There's a term called pregestational diabetes. So that means that someone had diabetes prior to the time they became pregnant. Those are usually represented by type 1 and type 2 diabetes. Type 1 diabetes is an autoimmune destruction of the pancreatic cells that produce insulin, and those patients are insulin dependent. Type 2 occurs when receptor sites at the tissue level are not responsive, causing resistance to the insulin produced. Again, those are called pregestational. We'll talk a little bit later about other specific types caused by infection or drug-induced. But the new one for you today possibly is gestational diabetes mellitus, or GDM, and it's any degree of glucose intolerance with the onset or recognition during pregnancy. So gestational diabetes is when the pancreas is unable to meet the increased demands for insulin production during pregnancy. And gestational diabetes usually isn't picked up until about the second half of pregnancy. The metabolic changes associated with pregnancy. Glucose is the fuel used by the fetus for growth and development. It crosses through the placenta, meaning that glucose levels in the fetus are directly proportionate to the glucose levels in the mom. But the insulin, however, does not cross the placenta. Around the 10th week of gestation, the fetus begins to produce its own insulin in amounts adequate to use the glucose obtained from the mother. So remember that glucose crosses from the mom to the fetus because her levels of glucose continue to rise to feed the fetus. The fetus's glucose rises, and then the fetus increases its insulin secretion. But remember, insulin doesn't cross the placenta. So it's a little bit of a confusing thing. Hopefully in the next several slides it'll help make a little bit more sense. So for pregestational diabetes mellitus, this occurs in women who have a pre-existing disease. Again, I mentioned type 1 and type 2. These are the patients that we're talking about. Their condition is their pregnancy is complicated by vascular disease, retinopathy, or nephropathy. All of these patients are insulin dependent. The normal hormonal adaptations of pregnancy affect glycemic control in pregnancy and may accelerate the progress of vascular complications. That's just scary in of itself because these women are going to, as we're going to talk about in a minute, are going to need a lot of pregestational counseling. They need to understand that if they have severe diabetes, pregestational, type 1 or type 2, there's a very high likelihood that their conditions are going to get worse even after they have the baby. Preconception counseling. The goal of preconception counseling, so this is before they get pregnant, is to minimize the risk of miscarriage and to deliver a baby with congenital anomalies from uncontrolled diabetes. Also, the goal includes to help optimize control of their blood glucose levels before becoming pregnant. It's going to be very important in this diabetic patient that they have very tight control over their glucose levels prior to getting pregnant. They want the hemoglobin A1C, which generally we want 6 or below. They want it below 7% before conception and during organogenesis. And if you remember, that's the very first almost 9 weeks of pregnancy. That's when all the organs are developing. So we want that glucose to be very much in control at that time to reduce the risk of spontaneous abortion and congenital defects. On page 268 in your text, you'll see the box about White's classification of diabetes in pregnancy. Class A through C, if you're looking at your text, usually have positive pregnancy outcomes. Class D through T usually have poorer pregnancy outcomes because they already developed they have vascular damage that's often found in type 1 and type 2. So their pregnancy is going to be much rougher and the outcomes much worse. Another part of preconception counseling is they're going to want to do a complete history and physical, assessing all the organs of the mom, her kidneys, her heart, everything involved, her thyroid, everything, just to make sure that she's in good enough shape and will have the most optimal outcome. Once she's pregnant, she's going to be having it throughout her antepartum period, but especially initially, she's going to have an in-depth interview. Again, they're going to be looking at all of her organs, seeing where she falls on the classification scale. They're going to do a physical examination. They'll do a routine prenatal exam plus an assessment of the effects of diabetes, such as the retinopathy that we talked about, the nephropathy, peripheral and autonomic neuropathy, peripheral vascular and cardiac involvement. This patient's also at risk for thyroid disease, so thyroid tests may also be done. For lab tests, they're going to get a baseline renal function, which is a 24-hour urine. And they're going to be checking it for protein and creatinine. And they may do a urine culture to rule out urinary tract infections. Again, these patients with diabetes are at very high risk for developing infections, especially urinary tract infections. They're also going to get a glycosylated hemoglobin A1C to assess glycemic control. And that's represented by the hemoglobin molecules are saturated with glucose, and that glucose will show up for the length of the life of the red blood cell. So that's about 120 days. So that kind of gives us a good view. It says 6 to 8 weeks, or 4 to 6 weeks, I believe it talks about, but it's really up to 3 months. I guess that would be 4 months, wouldn't it? Sorry about that. Okay, these patients need much more monitoring than the typical pregnant patient. During the first and second trimester, this patient, normally a pregnant patient would go in once a month. She may go in every 1 to 2 weeks. And in the third trimester, that's going to pick up to 1 to 2 times per week. The goal, they're going to be doing some fetal surveillance during that time, and the goal is to detect fetal compromise as early as possible and to prevent intrauterine fetal death or unnecessary preterm birth. They'll probably start with a baseline ultrasound and follow up every 4 to 6 weeks if possible. They're going to be monitoring for fetal growth. They're going to be looking for hydramnios, macrosomia, terms we'll talk about in a second, congenital anomalies. On page 277, they'll talk about the other tests that they'll be doing as well. And they'll also, towards the end of the pregnancy, be doing non-stress tests or fetal activity studies. Those are the primary tests to determine fetal well-being. When they're looking at target blood glucose levels to see how tight of control that glycemic control is, they're looking during pregnancy for the premeal or fasting glucose to be greater than 65 but less than 95. Post-meal 1 hour is going to be greater than 130 to 140. Post-meal after 2 hours, they want it to be less than 120. And 2 a.m. to 6 a.m., they want it to be greater than 60. Okay, some of the risk and complications involved with the mom and the fetus. Well, the first one is spontaneous abortion, also known as miscarriages. Those are related usually to inadequate glucose control in the first 7 weeks of pregnancy. And if you think about, again, the organogenesis, or when all the organs in the body's developing of that fetus, if the woman's blood sugar is out of control, that's likely to lead to a miscarriage or congenital anomalies. Pregnancy-induced hypertension. Pregnant women have twice the risk of developing pregnancy-induced hypertension, especially when vascular changes already exist. So these diabetic patients, especially type 1 and type 2, they're going to be at higher risk for pregnancy-induced hypertension. Hydramnios or polyhydramnios, that frequently develops during the 3rd trimester in the woman with diabetes. The cause isn't known, but it's possibly from the increased glucose in the amniotic fluid. Now remember about amniotic fluid that the fetus swallows it and then pees it out. So when you think about a person with diabetes, they have frequent urination, correct? So this increased hydramnios, increased amniotic fluid, is possibly from excessive fetal urination. Remember, the glucose also crosses from the mom to the baby, so if the mom's glucose is high, baby's glucose quite possibly will be high if the insulin's not taking care of it. This condition of polyhydramnios is associated with abruptio placentae, uterine dysfunction, and postpartum hemorrhage. PTL or preterm labor. This patient, the mom's going to be at risk for going into preterm labor because these babies are big. Diabetic moms produce, especially if the blood sugar is not under control, are going to produce a larger baby. That's called macrosomia, which we'll talk about with the neonate in just a second. But she also, if she has increased polyhydramnios or increased amniotic fluid, that's going to make her larger. All those things can increase her chance of going into preterm labor. Infections. Diabetes alter the body's resistance to infections. Yet with a pregnant mom with diabetes, she has an increased risk of vaginal infections, glucose in her urine. This later combines with the urinary stasis from the head and the softening of the cervix and the lower uterine segment. That's going to create a ripe environment for urinary tract infections and possibly even going all the way up to pyelonephritis. Ketoacidosis. DKA usually occurs in the 2nd or 3rd trimesters when the glucose-sparing insulin-resistance diabetogenic effect of pregnancy is at its greatest. The treatment also, another thing that we have to be worried about is the treatment of preterm labor with the breathing and corticoid steroid use used to mature fetal lungs may contribute to the risk of hyperglycemia and subsequent DKA. In your textbook, it goes through, there's a great graph, or table I should say, that describes the difference between hypoglycemia and insulin shock and hyperglycemia and DKA. It's table 11.2 on page 272, so please take time to read through that. That's very important to know. Hypoglycemia is most likely to occur in the 1st trimester during early postpartum and when breastfeeding. When you're thinking about the 1st trimester, these moms are they may have nausea and vomiting. They may not require as much insulin, but the body still may be producing insulin, so those moms, the blood sugars can kind of bottom out. So in the 1st trimester, women are more likely to have hypoglycemia than hyperglycemia. Now, in regards to the fetus, the neonate, fetus or neonate, once it comes out, they're very susceptible to birth trauma related to the macrosomia. Macrosomia, it's a large baby at birth due to the fetal pancreas beginning to secrete insulin. About 10 to 14 weeks, the fetus responds to the maternal hyperglycemia by secreting large amounts of insulin, or hyperinsulinism. The insulin acts as a growth hormone, causing the fetus to produce excess stores of glycogen, protein, and adipose tissue, leading to an increased fetal size, or macrosomia. This is a result of poor glycemic control in the mom, especially later in the pregnancy. So this baby will weigh generally greater than 4,000 grams or be greater than the 90th percentile. It occurs in 40% of pregestational diabetes mellitus and 50% in pregnancies complicated by gestational diabetes mellitus. When you're trying to visualize this, these infants are going to be bigger. They have bigger shoulders, trunk, their chest size. So when the mom's pushing this baby out, she has a greater chance of that head coming out, but because those big shoulders and chest, they might get stuck, and that's called a shoulder dystocia, which we'll talk about next week. You increase your chance of a C-section and birth complications. Remember, when the baby's so big, it may not fit through the pelvis, and so the woman may have something called cephalopelvic disproportion, meaning she can only go so far, the head will only get down so far because the rest of the body won't come down lower in the pelvis, and she'll end up requiring a C-section. Prematurity is secondary to preterm labor and an enlarged uterus, and possibly polyhydramnios. Those women are at risk for preterm and prematurity. And women with class D or higher diabetes who have pre-existing vascular disease before pregnancy, placental insufficiency may lead to intrauterine growth restriction. So that's called IUGR, intrauterine growth restriction. That's when there's limitations on how much circulating oxygen the baby's getting and nutrients, and so the baby doesn't grow as well. Also, prematurity is secondary to an issue called delayed lung maturity. And that may occur because of the interference with the production of surfactants from high blood sugar levels. So remember, surfactants, that's what holds the alveoli open. That surfactant really doesn't kick in until about 36 weeks, but that can even be postponed when the mom's and the baby's blood sugar levels are running high. So the infant of a diabetic mother may develop hypoglycemia within 2 to 4 hours after birth. Now we think about it, the fetal pancreas has been producing large quantities of insulin, and all of a sudden the baby's delivered and they no longer have that mom's glucose coming in. So the pancreas is still producing this insulin. So the abrupt decrease in blood sugar previously supplied by the mom through the placenta triggers hypoglycemia. In regards to congenital anomalies, there's many different anomalies that can happen. We can have central nervous system defects such as anencephaly, hydrocephaly, microcephaly, caudal regression syndrome, especially on that type 1, type 2 diabetes. So that's when they're doing the maternal alpha-fetoprotein, the serum alpha-fetoprotein. That's done early on in the pregnancy to detect any of those. Cardiovascular defects, such as septal defects or transportation of the great vessels. They could have ear deformities, single umbilical artery, as opposed to normally the baby has 2 arteries in 1 vein, so they might just have a single umbilical artery. The baby may have facial clefts, urinary system defects such as hydronephrosis or hydrospadias. Another cardiovascular one is coarctation of the great vessels, GI systems, and imperforate anal or duodenal atresia. Okay. Antepartum care. This one's a short slide with a lot, just like the last one, so I apologize about that, but there's so much to talk about regarding the care. So with the diet management during pregnancy, it's based on the serum glucose, not the urine glucose. You know how we always dip patients' urines, but when they're managing the patient's diet during pregnancy, it's going to be based on the serum glucose. They'll still dip the urine for ketones and protein possibly, but they're not going to be dipping it necessarily for sugar. The goal is to provide weight gain consistent with normal pregnancy, to prevent ketoacidosis, and to minimize wide glucose fluctuations. We want it to be slow and steady. We want this baby to grow at a very even rate, just like it's supposed to, like every other non-diabetic patient or pregnant mom. Our goal is euglycemia, it's euglycemia, which is a normal blood glucose. So you have this woman who all of a sudden her needs are going to change. She's maybe been insulin dependent, but she's used to managing her own care, and all of a sudden her needs are going to change tremendously because of the growing baby inside. So this not only is a challenge for the pregnant mom, it's also for the family. Everyone needs to be on board with all of this, these new changes. So education, education, education. In order for her to be compliant and to be flexible with all the changes that are going on, she's really going to need to understand how important this is for her well-being as well as the baby's well-being. So urine testing we talked about, with no glucose testing in the urine, but they do check for ketones and protein. Determination of birth date and mode of birth. As the pregnancy progresses, they strategically probably don't want to carry that baby to full term, not till 40 weeks, unlike a traditional birth of a non-pregnant mom. They're going to want to deliver this baby a little bit early, but one of the key factors is going to be whether the fetus's lungs are mature. And again, I mentioned just previously that they're going to be a little bit delayed because of that surfactant if the glucose levels are elevated or out of control. So some of the complications requiring hospitalization include infection that can lead to hyperglycemia and DKA, poorly controlled glucose, they may have to be hospitalized because of that, and also hypertension because this mom is at risk for pregnancy-induced hypertension. And I mentioned briefly about the fetal surveillance earlier. This is why she has to come in more frequently so they can do serial ultrasounds, non-stress tests as she gets further along, checking for any fetal anomalies. We want to reinforce the signs and symptoms of hypoglycemia, such as nervousness, headache, fatigue, shaking, irritability, tachycardia, hunger, blurred vision, sweaty skin, tingling of the mouth or extremities, especially in the first trimester. The mom's going to need to know those signs and symptoms. We don't want her to bottom out on her blood glucose. That can cause so many problems for the baby. So we're just going to want to make sure that she's well educated on the signs and symptoms. I gave you this handout, I believe, but it kind of talks about what the insulin requirements are and their implications. So I'm just going to go through them briefly. I will be reading this to you. First trimester, it's decreased due to the inhibition of the anterior pituitary hormones and the growth of the embryo and the decreased maternal intake. The insulin dosage and diet must be adjusted for the pregestational diabetic. The blood sugar can be unstable. Nocturnal hypoglycemia can occur. Remember I said it between those early hours in the morning it needs to be greater than 60. Morning sickness can influence oral intake, and an unstable glucose levels increase the risk of miscarriage. There's a graph in your chart, let's see what page, on page 269, that shows the fluctuation of the insulin needs during pregnancy. And this kind of goes along with that. But it gradually increases during the second trimester, 10 to 20% for type 1 and 30 to 90% for type 2 due to insulin-resistant properties of placental hormones. So the insulin dosage may need to be adjusted every 5 to 10 days. So think about the amount of monitoring that's going to require on her part. So monitor blood sugars frequently, at least fasting, before and after lunch, before dinner, and at bedtime. If fasting blood sugar is high, test the blood sugar between 2 and 3 a.m. Adequate glucose level is needed for fetal growth. Third trimester, it continues to increase until about week 36 when it reaches a plateau, and then it may decrease slightly as placental functioning diminishes. Especially if she goes over dates, that placenta is not going to be working as well. Or post dates, I should call it. And the implications are the same as the second trimester. With labor and delivery, though, it decreases during active labor due to increased metabolism. So you're going to monitor the blood glucose and urine for ketones every 1 to 2 hours. We're going to adjust the IV fluids according to blood sugar and give IV fluids with glucose if they're needed. if blood sugar glucose falls below 70. We usually don't. We try to avoid giving any of that glucose, but sometimes we need to give glucose and also give insulin, and we give regular insulin in labor. Because it's quick acting, we can stop it if we give an insulin drip. But it is a little confusing when you walk into a diabetic patient's room and they have glucose as well as insulin going at the same time. Some women may require insulin infusions and adjust according to their blood sugar and their ketones. Postpartum shows a markedly and rapidly decreasing insulin requirements because of the loss of the placental hormones. So once she's delivered, she doesn't have those same needs. Pregestational diabetics should continue to monitor their blood glucose and urine ketones. Insulin needs will return to about 2/3 of the pre-pregnancy dosage by postpartum day 4. Gestational diabetics should monitor blood sugar and ketones for at least 24 hours and usually do not require insulin postpartum, but we do want to keep an eye on those patients. What we started noticing about 15 years ago is that a lot of our gestational diabetics were coming in and we weren't monitoring them after they delivered the baby, maybe just one quick check, and then we didn't really worry about them. But some of those patients, we started noticing that they were coming back into the doctor's office not feeling well. It turns out they were truly type 2 diabetics. They had just not ever been in the hospital situation or never gotten checked for it. So type 2 used to occur just in older generation, people in their 60s and 70s, and now we're finding it because due to obesity and overweight, patients are becoming type 2 very early, and sometimes when they're of childbearing age. So we don't ever want to rule that out. And we'll talk about in a minute that a lot of physicians in ACOG, actually, the American College of Obstetricians and Gynecologists, recommends oral glucose testing even 4 to 6 weeks out after delivery. So breastfeeding is considerably decreased because of the carbohydrates used in milk production. So breastfeeding should be encouraged. You want to increase the calories to about 500 to 800 more. Close glucose monitoring is needed. Expect fluctuations when you're trying to wean the baby. Increase the risk of nipple infection and mastitis due to the if the glucose levels are high. She's going to be more prone to infections. This is just an example of one of the pumps that they use in antepartum to help control the blood sugar. I'm not sure if any of you have any experience working with these, but they're very convenient. The mother doesn't have to, or the patient doesn't have to draw her insulin up all day long, or you can just kind of adjust it accordingly. It's a really nice, they've been doing it for quite some time, but it's a really nice feature. In regards to care management, I kind of went through some of those things in that slide a minute ago, but intrapartum care, we're going to monitor these patients, intrapartum meaning during labor and delivery. We're going to monitor these patients very closely, watch their blood sugar and watch their insulin requirements. We're going to be on alert for the complications that we talked about. These patients may require cesarean birth, and also for the reasons that we talked about with the macrosomia or the very large baby or the hydramnios or any of the multiple conditions that can create that. In regards to postpartum care, the insulin requirements decrease substantially. We're going to encourage the breastfeeding, and we need to focus on contraception. This mom needs a lot of time to heal, so we want to make sure that she's not back in pregnant again. Now, gestational diabetes mellitus, again, that's a situation that happens. She's never been diagnosed with diabetes before, and all of a sudden now she's diagnosed with it. It's about halfway through the pregnancy. So gestational diabetes accounts for 3 to 9% of all pregnancies. And you'll hear me use percentages as I talk. In preparation for all of these things that I'm going to be doing PowerPoint presentations on, I look at several different textbooks. I look at your textbook. I look at board review books. And so there's such a wide variety in percentages. When I can, I'm going to try to use the percentages that are in your particular textbook. And for testing purposes, you'll always have that to fall back on if I do happen to put a percentage on a test question. But I don't anticipate doing that. It's because I'm telling you, all the statistics are different almost in every textbook. So try not to get too worried about any of those things, but just kind of have an idea of how important are these percentages in terms of 3 to 9% of all pregnancies account for gestational diabetes. That's a pretty significant amount. We're noticing an increased rate of gestational diabetes due to overweight and obese women. Under White's classification, gestational diabetes is classified as A1 and A2. All pregnancies are usually screened between 24 and 28 weeks or earlier if the patients delivered a previous baby that was macrosomic or large, greater than 4,000 grams, or has ever had any of the other conditions. But gestational diabetes is usually diagnosed in the second half of pregnancy. We don't really see a huge incidence of birth defects, increased incidence of birth defects with gestational diabetes like you do with the congenital anomalies and birth defects with the traditional type 1 and type 2 diabetes, because it's not really developing until the first trimester, is after the first trimester when the organs are already formed. Although your textbook does make reference to one study where obese women with a BMI greater than 30 kilograms per meter squared, they developed gestational diabetes, and they were at greater risk to give birth to infants with CNS defects, meaning that those patients were prone to get gestational diabetes, and that did impact the organ development in the first trimester. Okay, so monitoring the glucose levels. That's usually when she gets up in the morning, after breakfast, before and after lunch, after dinner, and at bedtime. They're very similar to the pre-gestational glucose levels. Insulin therapy. 25% of gestational diabetics require insulin. We want the fasting to be greater than 95. That would be a qualification, excuse me. 2-hour postprandial greater than 120. Insulin is begun at that time. Fetal surveillance. If the gestational diabetes and hypertension or a history of stillbirth or macrosomia, they're going to be doing these non-stress tests twice a week, starting at about 32 weeks. So they're going to be really monitoring these babies for growth and development as well as too much growth, and try to do a strategy as to when they can deliver this baby so it has a greater chance of survival. And intrapartum care, there's a care plan on page 281 I'd like you to look through. During labor, they're going to try to maintain that blood glucose at 80 to 120 milligrams per deciliter. Okay, in postpartum care, most of these patients, as I mentioned, return to normal glucose levels after childbirth. However, reoccurrences with the next pregnancy are high. Obese women are at greater risk of developing type 2 diabetes once they've been a gestational diabetic. And as I mentioned, ACOG recommends an oral glucose test 4 to 6 weeks after birth on patients with gestational diabetes, because they want to see if they're truly just gestational or if they're a type 2 diabetic person that hasn't been diagnosed yet. This is an example from your text on oral glucose tolerance test. It's a 2-step method that's used in the United States. As you'll notice, it's the first screening's a 50-gram oral glucose load, or something they ingest, with 1 hour post-serum glucose. This woman doesn't need to fast for this. It'll be during one of her normal prenatal visits. They'll probably do this. If it's greater than 130 to 140, it's considered positive, and she'll be followed up by a 3-hour or 100-gram oral glucose tolerance test. That does require fasting. The fasting's an example. The fasting is drawn. They drink 100 grams of the glucose solution. Then they monitor the blood glucose levels. They're drawn at 1, 2, and 3 hours later. If 2 or more values are met, meaning they're in the high range, the bottom of this picture on the right, then she's considered to be gestational diabetic. But if, going back up to the left-hand side of the chart, at the 1 hour glucose, if her blood glucose is less than 130 to 140, then she's considered negative and she just has routine prenatal care. That's for the non-diabetic patient. That's what this screening is for all patients. Okay, now I'd like to talk just briefly about hyperthyroidism or thyroid disorders, and also hypothyroidism. To differentiate between normal signs and symptoms of pregnancy, Graves' disease also has some of the same signs and symptoms, such as heat intolerance, fatigue, diaphoresis, anxiety, emotional lability, meaning your emotions go up and down, and tachycardia. But to see which one it is, if it's Graves' disease or if it's just normal signs and symptoms of pregnancy, if there's weight loss, or if a goiter is palpated, or if the pulse is greater than 100 beats per minute, it's probably or quite likely Graves' disease. It doesn't happen very often, but it can happen. The labs will reflect an elevated T3 and T4 and a decreased TSH. The drugs that they treat with do have some side effects, so PTU and MM, or polypropylthiouracil, and Mazzoli, I can never pronounce that one. They both have potentially dangerous side effects, as I mentioned. Page 282 in your book talks about it. They're generally going to give the PTU during the first trimester and the MM for the second and third trimester. I also want you to pay attention to the nursing alert on page 282, and this is the risk of a pregnant patient having a thyroid storm, which is very significant. So during the first trimester, it's critical to have normal T4 levels for brain development for this baby. So we're going to, remember I mentioned as part of pre-genetic or pre-counseling, pre-conception counseling, they may do thyroid tests as well, because it is linked to the diabetes. Well, it's just going to be super important for brain development that they are maintaining on the right drugs that they need for those T4 levels to be within normal. Hypothyroidism is linked to infertility. Well, actually, severe hypothyroidism is linked to infertility and increased risk of miscarriage. In the United States, it's not very common, but in the rest of the world it is, with iodine deficiency in maternal, fetal, and neonatal populations. Pregnant women with hypothyroid are at risk for miscarriage, preeclampsia, gestational hypertension, placental abruption, preterm labor, and stillborn. The treatment is Synthroid. Iron absorption is less with Synthroid, so they're going to have to take it at a different time. If they take their Synthroid in the morning, they're going to take their iron, their prenatal iron, or just their iron pills later in the day. I'd like to talk about maternal fetal ketonuria, also known as PKU. It's a recognized cause of mental retardation caused from the deficiency of the enzyme phenylalanine hydrolase. Since 1961, all newborns are screened for PKU. They must maintain strict phenylalanine restrictions before conception and continue throughout pregnancy. Toxic accumulation of phenylalanine in the blood interferes with the brain development and function. The key to prevention is identification of women with this disorder in their reproductive years. These women should be advised against breastfeeding. Again, if they are pregnant, though, the dietary modifications include excluding all high-protein foods such as meat, milk, eggs, nuts, and wheat products, very similar to a vegan diet. They'll be measuring the phenylalanine levels 1 or 2 times a week throughout the pregnancy. The levels greater than 6 have been linked to microcephaly, cognitive impairment, and congenital heart defects in their children. Part of what I do when I'm getting ready to prepare for a lecture like this is that I review several different board review books. Probably I have about 7 of them in my room right now. I've been reading those. I've been reading different textbooks, trying to get an overview. Sometimes when you're just looking at one textbook, it kind of goes on, and I kind of enjoy things when they're in a nutshell. So this is my version of cardiovascular disorders in a nutshell. Cardiac disease, occurs in up to 2% of pregnant women. The classification of heart disease is usually based on the functional capacity of the heart. It can be reclassified as the pregnancy progresses. The pregnant woman is most vulnerable for cardiac complications from week 28 to 32 of gestation, and in the first 48 hours postpartum. Vaginal birth is usually preferred because there's fewer hemodynamic changes than with a cesarean delivery. Although we will want to note a little bit later, they'll probably want to make sure that this woman doesn't push. She's going to want to deliver via epidural and let what they call labor down, where she's not actively pushing, but they just get her comfortable and allow that baby's head to come down on its own. It takes a little bit longer, but it's better for her in the long run. So after 36 weeks of gestation, labor may be induced if the fetal lungs are mature. Women with cardiac disease can breastfeed if they're careful, and maternal hypoxemia increases the incidence of miscarriage, intrauterine growth restriction, fetal hypoxemia, preterm labor and birth, and stillbirth. Antibiotics are given prophylactically in women with mitral valve prolapse to prevent bacterial endocarditis. Here we have cardiovascular disease classifications, and this is how they affect labor. So class 1 is asymptomatic without limitation of activity, and those patients usually experience normal pregnancy, labor, and birth with no restrictions. Class 2, those patients are symptomatic with slight limitation of activity. Pregnancy, labor, and birth may worsen their symptoms. They need careful monitoring for decreased functional capacity of the heart. Slight activity restriction may be advised, and excessive weight gain should be avoided. Class 3 are patients who are women who are symptomatic with less than ordinary activity, but they're really truly only comfortable at rest. Marked restrictions of physical activity is advised. They can have severe cardiac complications during pregnancy, labor, and birth, and early in the postpartum period. Class 4, these patients are symptomatic at rest. They're unable to perform physical activity because of cardiac insufficiency. Pregnancy would not be recommended because of increased maternal and fetal morbidity and mortality. Major cardiovascular changes during pregnancy that affect women with cardiac disease are increased intravascular volume, decreased systemic vascular resistance, cardiac output changes during labor and birth, and intravascular volume changes that occurred just after childbirth. Now, pathophysiologically, we know, I think you know already, that the blood volume increases up to 30 to 50%, and the pregnant patient's in a hypervolemic state. She shows a 25% increase in her red blood cell count, her volume, and a 50% increase in the plasma volume. So it's kind of unique physiological challenges with these cardiac diseases, but if you look at the RBCs increase versus the plasma increase, what do we see here? We're going to see hemodilution or physiological anemia. And we're going to talk about anemia, especially a physiological anemia, a little bit later when we talk about that condition. We're also going to see increased stroke volume and heart rate, decrease in systemic and pulmonary vascular resistance, and there's also a decreased blood pressure. And the patient will be in a hypercoagulability state, and so she's at risk for arterial thrombosis. These are all the cardiovascular conditions that your textbook talks about, and for test purposes you're really not going to need to know all of them. You've probably, I'm guessing, already studied them. If not, you will be studying them next year. But congenital cardiac diseases, or the left to right shunts, those are atrial septal defect, ventral septal defect. Your textbook gives good explanations of all of them. So for general education, I think it's not a bad plan to review these if you're not familiar with them. You have cyanotic congenital heart and acyanotic. Well, coarctation of the aorta is an acyanotic congenital heart lesion. You have cyanotic congenital heart lesions, which is also called tetralogy of Fallot, which encompasses 4 different conditions, heart conditions. There's acquired cardiac diseases such as mitral valve prolapse, mitral stenosis, and aortic stenosis. Ischemic heart disease such as a myocardial infarction. And other cardiac conditions that your book talks about are pulmonary hypertension, pericardium cardiomyopathy, infective endocarditis, Eismenger syndrome, Marfan syndrome, and heart transplants. And the one thing, it's amazing, when I was reading this in your text, it talked about heart transplant patients, how they need to wait at least a year before becoming pregnant. But the exciting thing is, if everything's going well with the transplant and the woman has normal cardiac function at the beginning of the pregnancy, these patients usually do well with labor and birth. Some women develop hypertension and may have at least one episode of organ rejection, which is awfully scary, but it's amazing. I just think it's incredible that heart transplant patients can deliver successfully. These are the kind of things that could possibly be on your state boards, or cardiovascular decompensation. It's recognizing these symptoms to know when a pregnant patient with pre-existing cardiovascular disorders is at risk. So the subjective symptoms that she might present with would be increased fatigue, difficulty breathing with activities, normal routine activities. She might complain of feeling a smothering or a frequent cough. Her heart may be racing. She may present with swelling in her face, in her hands, her feet, and legs. Objectively, she might have an irregular, weak, rapid pulse greater than 100. She might have progressive generalized edema. In pregnant women, especially hospitalized patients, an area that we often forget to look for edema is going to be sacral edema, so it's going to be in her lower back, especially patients who are on bed rest for things like preterm labor and things, but just a FYI. When we're talking about edema, we just don't mean the hands, legs, and face. We're also going to look for that sacral edema. The patient may have crackles at the base of the lungs that don't clear with coughing. She may have orthopnea and increased fatigue, rapid respirations greater than or equal to 25, and a moist, frequent cough. I did notice in one board review book they talked about a dry cough, but the majority of the things said moist, frequent cough, which would go along with some of the crackles. And cyanosis of the lips and nail beds. And I mentioned earlier too, the most dangerous time for cardiac decompensation on a pregnant woman is going to be during weeks 28 to 32 when her blood volume is at its peak. Maternal symptoms depend on the source of the problem, if it's right-sided failure, left-sided failure, or with pre-existing cardiac conditions that I mentioned on page 284 to 288. You may have seen this slide before, but it kind of goes over right-sided heart failure with fatigue, increased peripheral venous pressure, ascites, enlarged spleen and liver, distended jugular veins. She may complain of anorexia or complaints of GI distress, swelling in her hands and her fingers, independent edema. Right-sided failure would include the pulmonary valve stenosis, atrial septal defect and ventral septal defect, congestion in the systemic venous systems. It causes decreased cardiac output to the lungs. The most likely causative agent in childbearing age is the Eisenmenger syndrome, which is a right to left shunt, meaning the non-oxygenated blood from the right atrium or ventricle leaks into the left side of the heart, causing a mix of the blood being sent out to the rest of the body. This condition is associated with high mortality. 50% in mothers and 50% of the fetuses die. Pregnancy is not recommended in women with this condition, and pregnancy may be terminated if she becomes pregnant due to the poor pregnancy outcomes of mom and baby. Women who choose to continue the pregnancy require strict limitations on activity. If you want to dig a little bit further in Chapter 11, page 287, for further considerations with this. On the left side of the heart, we have paroxysmal nocturnal dyspnea, elevated pulmonary capillary wedge pressure, cough, crackles, wheezes, blood-tinged sputum, restlessness, confusion, orthopnea, tachycardia, exertional dyspnea, and cyanosis. These causative agents are usually mitral stenosis, mitral insufficiency, and aortic coarctation. The heart becomes overwhelmed. It has an inability to push blood forward. This causes a back pressure on the pulmonary circulation, causing pulmonary system to become distended. The systemic blood pressure decreases in the face of the lowered cardiac output, and pulmonary hypertension occurs. Pulmonary edema produces profound dyspnea as it interferes with oxygen and the carbon dioxide exchange, where fluid coats the alveolar exchange spaces. They may get frothy sputum, and look exactly like this picture if you've ever seen anybody in pulmonary edema. Cardiovascular disorders show an increased incidence of miscarriage. These patients are more apt to go into preterm labor and preterm birth. They have intrauterine growth restrictions more common. The incidence of congenital heart lesions increased in children of mothers with congenital heart disease. Care management, preconception counseling to understand the risks. If this pregnancy was unplanned, this woman early in the antepartum period is going to require some counseling to explore the couple's desire to continue the pregnancy in light of the risks involved. You're going to want to teach this client to report any symptoms of cardiac decompensation. Remember that big list. Encourage 8 to 10 hours of sleep each night and daily rest periods. We're going to teach self-administration of heparin if it's prescribed. Give the patient a diet plan which includes high iron, high protein, and adequate caloric intake. And inform the patient of anticipated difficult period for control at 28 to 32 weeks when plasma volume peaks in pregnancy. Intrapartum. We want to try to maintain a calm atmosphere, allowing the presence of support persons and keep the family informed at all times. We're going to maintain cardiac perfusion. We're going to put the patient in a semi-Fowler's but sideline position. We're going to prevent Valsalva maneuvers even during second stage. The second stage is when they're completely dilated and they go into the pushing phase, or the baby's continuing to descend the rest of the way. But doing bearing down, like they talk about with the Valsalva maneuver, it obstructs the left ventricular outflow, and this can cause increased stress and cause the mom to have more problems. We're going to avoid hypotension if the patient gets epidural anesthesia. And what we commonly do when we're getting ready to give an epidural is we preload. We give them a liter of fluid just before we give the epidural because it's been shown to lower blood pressure a little bit. Not all patients, but some patients do respond that way by having their blood pressure bottom out, and that's always why we're monitoring them so closely after a woman first gets an epidural. So we definitely don't want this patient to get hypotensive. We're going to avoid stirrups during delivery. That can cause the popliteal vein compression and decrease the venous return. We're going to provide pain relief and supportive measures because pain can contribute to cardiac stress. We're going to monitor forceps delivery and episiotomy. It will likely be performed to decrease the time of the second stage of labor. So what they're talking about is if that baby's not laboring down, if it's not low enough at we'll talk about the station that the baby's at as it descends down into the pelvic, getting ready to birth. And once it gets low enough that they can maybe put a vacuum forceps on, they'll probably, and as long as the patient's comfortable with her epidural, they'll probably do an episiotomy and try to get the kid out that way as opposed to having her bear down at all, because that's just going to be too hard on her system. Postpartum, we're going to tailor the care to the woman's functional classification. We're going to continue semi or high Fowler's position, the head of the bed raised, with the side line maintained. We're going to try to get her on her side. We're going to progress ambulation from dangling to sitting to standing, from short to long ambulation sessions according to tolerance and absence of cardiac decompensation. We want to administer stool softeners as prescribed to prevent straining during bowel movements, and we're going to watch for symptoms of urinary infection or painful urination, white cells in the urine and pus in the urine. Report any symptoms of cardiac decompensation to healthcare providers immediately. Tachycardia being pulse greater than 100, tachypnea, respiratory rate greater than 24 if she has moist cough or crackles in the lung bases. Report immediately any temperature spike above 100.4, and plan with the mother and family for support when returning home. If necessary, refer to community resources for homemaking help or help around the house. Plan and care of implementation. This patient may be on heparin. It's a large molecule drug. It does not cross the placenta. During intrapartum care, the care focuses on promoting cardiac function and prophylactic antibiotics. Again, if she has an infection, we don't want her to get that bacterial endocarditis. And postpartum care, monitoring for cardiac decompensation. Now I'd like to talk about anemia and anemia during pregnancy. Anemia during pregnancy decreases the oxygen carrying capacity of the blood. It affects from 20 to 60% of pregnant women and can be caused by inadequate nutrition, maternal adaptation to pregnancy, and genetic defects in red blood cell production. The increase in blood volume that occurs during pregnancy can lead to physiological anemia. Now, do you remember when I was talking about that hemodilution? Here we have physiological anemia of pregnancy, or kind of like a pseudo-anemia. It's when the red blood cells, they're needed to transport oxygen to the fetus. That's why we have an increase. We have a 25% increase in pregnancy, approximately. And we need those red blood cells to increase because they're going to be carrying the oxygen that's going to go to the fetus. And the plasma volume increase is about 50%. But because the plasma increase exceeds the red blood cells by twice, that causes a drop in the hemoglobin and hematocrit, which causes a state of hemodilution. So their levels are naturally going to be a little bit lower when those plasma and red blood cell levels are at their highest. But true anemia is considered a hemoglobin of less than 11 grams per deciliter in the first or third trimester, or in the second trimester a hemoglobin of less than 10.5 is considered true anemia. Severe anemia is a hemoglobin of less than or equal to between 6 and 8 grams per deciliter. And recently we saw a patient in the hospital, a pregnant woman, with a hemoglobin of 6.6 and a hematocrit of 21. And normally we don't want that hematocrit to be below 33%. Anywhere from 33 to 35%. We really don't want the hematocrit any lower than that. And they were going to give her a blood transfusion, but she refused, and she still had about 9 more weeks to go before she was full term. So it was interesting. I had an opportunity to talk to the neonatologist to see, and the hematologist put the pregnant patient on iron and thought that after a week it's going to come up at least a gram, so that would put her up about 7.6 if she took the iron 3 times a day. Well, a lot of patients who are in that situation aren't compliant with that regimen of taking iron 3 times a day. It's also going to cause extreme constipation for her, and when she already has a baby sitting down there and then you impact her bowel with stool, it can be a very uncomfortable situation. So I'll be interested if we get an opportunity to see how that plays out. But the neonatologist said that iron stores can be replaced quickly, and the baby's going to take from the mom. It'll leave the mom without any iron, but it's going to take from the baby's going to steal the mom's iron from her body to help his or her overall health. So babies can do well with this situation, but the concern comes if she's in labor or if she has any type of bleeding episodes. She won't have enough hemoglobin to help circulate oxygen to the baby, so it could become an emergent situation if she has any type of bleeding. They're not sure also if it was a sickle cell issue, so they were going to be investigating that a little bit further. But very interesting, because she falls definitely in the severe anemia with that hematocrit of 21 and the hemoglobin of 6.6. Now I'd like to talk about some of the different types of anemia. We have iron deficiency anemia, which is the most common type of anemia during pregnancy. It carries with it an increased risk for infection, delays healing time, and decreases energy for the postpartum period. The fetus will receive the necessary iron for growth and development, while the maternal iron stores become depleted, leading to symptoms of anemia. This is common when women don't want to take their prenatal vitamins that have extra iron, and especially if they're iron deficient. What happens is that they end up getting a permanent depleted state, and it can take them a very long time to try to recover and get that strength back postpartum. But the baby will get what it needs, and but it leaves the mom kind of empty and feeling horrible. Treatment includes dietary counseling. They're going to be taking supplemental iron. We really need to educate these women, remind them that the iron is going to assist with oxygen transport and carbon dioxide transport. It aids in the production of red blood cells. It plays a big role in the body's immune system. So we're going to talk about pica. Pica is when the woman has abnormal cravings for clay and things that are not edible. Iron supplementation is going to be important that they maintain that and they don't forget their iron supplements. Women can be transfused with IV or IM. IM hurts tremendously, so normally they're just going to take it orally. We want to make sure they're taking their prenatal vitamins, and we're going to want to increase in their diet with meats and green leafy vegetables. Remember that iron can cause severe constipation, so we're going to want to make sure that they have a stool softener or something to help. Folic acid deficiency. Folate's a water-soluble element. It's found in green leafy vegetables, citrus fruits, eggs, legumes, and whole grains. It's a common deficiency, especially in pregnancy, due to the increased fetal demands and because it's less well absorbed from the GI tract during pregnancy. The recommended intake of a non-pregnant woman is going to be 400 micrograms per day, where a woman who's pregnant is going to be 600 micrograms per day. Without it, with a deficiency, these women are at risk for neural tube defects. And the CDC recommends all women of childbearing age take extra folic acid. It's the most accurate time before pregnancy, in early pregnancy, to help with spinal cord development. Thalassemia is a congenital disorder in which there's a defect in the hemoglobin formation causing a shortened lifespan of the RBCs. It's usually seen in people with Mediterranean or Southeast Asian descent. There's two different categories. It's really called beta thalassemia, and there's beta thalassemia minor and beta thalassemia major. Minor is when they only inherit one gene, and it doesn't really have a huge effect on pregnancy. The major, though, that's also called Cooley's anemia, and that's where they're inheriting a gene from both parents. It's much more serious. Usually the woman's infertile. Those women often die earlier in life due to infection or cardiovascular complications. They have lifelong issues with hemolysis, anemia, and they risk premature death. If they do reach childbearing age and get pregnant, medical care is much like sickle cell during pregnancy. In this slide, I tried to compare and contrast a little bit sickle cell during pregnancy when a woman has the sickle cell trait or when she has the actual disease. So it's from sickling or abnormal shape of these red blood cells. The normal, when someone's carrying a trait, they have sickling red blood cells, but they have a normal 120-day red blood cell lifespan. Those patients are usually asymptomatic. They do require genetic counseling and partner testing because we want to see, especially preconception, because we want to see what the risks are, and we all did that. We've all done those Punnett squares, so we know what % chance they have of actually carrying the trait, or whether they have a chance of an offspring having the disease. These women, though, even though they're carrying the trait, they're still at risk during their pregnancy of preeclampsia, and intrauterine fetal death. That's what IUFD means. Preterm birth, low birth weight infants, postpartum endometritis, increased urinary tract infections, and a decreased iron. Sickle cell disease, their average lifespan is only 5 to 10 days as opposed to 120 days. It occurs in 1 in 708 African Americans in the United States, according to your text. These patients have recurrent crises, usually triggered by dehydration, hypoxia, or acidosis. They require genetic counseling due to poor pregnancy outcomes, miscarriage, intrauterine growth restriction, and stillbirth. We're going to monitor for preeclampsia and urinary tract infections. They're going to do serial ultrasounds on these patients to assess fetal growth and development. Anytime this woman comes down with an infection, we're going to want to treat it quickly. Anything that could cause dehydration or hypoxia or acidosis. When she's laboring, we're going to keep her on her left side, keep her well hydrated, and give her extra oxygen. The last category we're going to talk about is substance abuse. The continued use of substances despite related problems in physical, social, or interpersonal areas. Substance abuse often shows up with another psychiatric disorder. Mood disorders are one of the ones that women often are found to have. It can have damaging effects on the fetus, and they're very well documented. So mood and anxiety disorders along with substance abuse in women. Alcohol and other drugs easily pass from the mother to the baby via the placenta. Smoking during pregnancy may cause bleeding complications, miscarriage, stillbirth, prematurity, low birth weight, and sudden unexplained death. Congenital anomalies can occur in infants of mothers who have taken drugs during pregnancy as well. If a mom is addicted to opioids, methadone is the current standard of care. And unfortunately, I've seen way too many cases in my years as a labor and delivery nurse. With cocaine and crack use, it can lead to preterm labor because of placental abruption. Due to all the vasoconstriction, it cuts off oxygen to the placenta. The placenta starts to separate, and I've had a patient start pushing from 5 centimeters on, and the baby was delivered complete in the amniotic sac and all, because the mom was on crack. Or she was coming off of crack at the time I had her, but it was very much a shame because the baby was only 5 months along and the outcome wasn't very good. With substance abuse, there's some barriers to treatment. Women fear losing custody of a child in criminal prosecution. Less than 10% of pregnant women receive treatment. Substance abuse treatment programs do not address issues affecting pregnant women, and long waiting lists and lack of health insurance present further barriers to treatment. The book states that 15% of all pregnant women have substance abuse problem. That was shocking to me, I think. 15% of our population is a large amount of people. I can say, though, that working in the hospital, even at Genesis, teaching in the nursery, we've seen we'd see majority of the drug cases and drug withdrawal cases over at Hurley, but we're seeing a lot more at Genesis. We've seemed to have a run on them the last couple of years, but a lot of Vicodin addiction and some other, common drugs. But it was really sad, and the babies have to go through the withdrawal, and we'll study that a little bit more when we talk about the newborn in a few weeks. So during treatment programs, child care and prenatal care need to be addressed as well. There's so many repercussions. They get treated poorly in the hospital. These women have a serious, serious problem, and they're scared to death to talk to anybody about it. Sometimes they just try to avoid it all because they want to keep using. So there's just a huge amount of issues that surround this topic. Care management, we look at drug testing during pregnancy. Most women are tested for drugs if they have any type of history. Your book talks about questions to ask. There's 5 questions called the 4 Ps. It's an interesting thing I'd like you to look at. Screening for substance abuse, initial care, what they're coming in for, how they're going to try to manage the substance abuse, especially if we know about it. The methadone maintenance program, that's for patients who can't get off drugs, and they're going to be followed up. Breastfeeding is definitely contraindicated in women who continue to use amphetamines, alcohol, cocaine, heroin, and marijuana. Substance abusers, difficult to care for, particularly during intrapartum and postpartum periods. A lot of guilt involved with that. I know I've had many users of harder drugs, even like crack, and as soon as they push that baby out, one woman's first comment to me was, "Is my baby okay? Is my baby okay?" And she appeared so genuine in her worry and her concern, even though during her whole pregnancy she used drugs. And it's really trying to find a peaceful place, not being judgmental, knowing that it's a severe illness. As this mentions, women deserve to be treated with patience, kindness, consistency, and firmness. I always looked at my time with those patients, and I had a lot of them at Hurley when I was there for my 18 years. I always used that time as, I think I may be the only reasonable adult that they see. So I always want to educate, and I had pretty good response and pretty good rapport with those patients. And if someone's not passing judgment on them, they're more open to listening, and to maybe you'll actually be able to make a difference. So I hope that happens with you if you have an opportunity to come across this kind of patient, that you'll treat them with the kindness and respect, and just know that you may be a role model for them. You may be setting the stage for a change in their life that's for the good and for positive. So before discharge, they may need to assess the home situation, make sure they're taking the baby home in a safe environment. I believe we talked about in class a little bit too that who draws the line whether the child gets to go home. And I know a lot of kids do go home even if the environment is not stable, and that's just difficult to see. But we do want to follow through with social workers if we suspect anything, or we can always test the baby stool for meconium. We can test the meconium stool for drugs as well. You can test hair. There's all sorts of different ways to test to see if these, how recently, if the mom denies using drugs, we can still check. We want to make sure there's someone's available to meet the infant needs if the mother is unable. Family members or friends should become actively involved with the mother before discharge. Again, it depends on who her friends are, and if she's going back into an environment where she's going to be using again, we're going to have to look at some intervention there, maybe a foster situation until things can be straightened out at home. If the infant's well-being is questionable, the case will be referred to Child Protective Services Agency. And this is just a question. During a prenatal visit, the nurse is explaining dietary management to a woman with pregestational diabetes. The nurse evaluates that teaching has been effective when the woman states, "I will need 600 more calories per day since I am pregnant." Or B, "I can continue with the same diet as before pregnancy as long as it is well balanced." C, "Diet and insulin needs change during pregnancy." Or D, "I will plan my diet based on the results of urine glucose testing." And the right answer is C, "Diet and insulin needs change during pregnancy." So that's the end of our lecture today, and I hope you're doing well. I will talk with you soon. Thanks. Bye.